Welcome to our program, Building a Path to ICD-10, brought to you by the Cooperative of American Physicians and CAPS Practice Management Services Committee. This program is part of the Surviving and Thriving Through Healthcare Reform webinar series. And it's my pleasure to introduce today's speaker, Mary Jean Sage. As founding principal and senior consultant of the Sage Associates, Mary Jean Sage is a nationally recognized speaker, consultant, and educator with over 20 years of experience in healthcare. Her unique blend of administrative and clinical skills has earned her an enviable reputation as an expert in managed care operations and reimbursement management. She is recognized nationally for her expertise in coding and billing and for the practical seminars and workshops she presents to healthcare professionals. Ms. Sage was instrumental in developing the Certified Medical Billing Associate Program, which credentials medical billers, and served as the initial certification director for that program. She currently serves as an advisor to a number of billing and coding publications. Ms. Sage received her degree in business administration from the University of Redlands and her degree in allied health from Ferris State University. So you're in for a terrific presentation. It's my pleasure at this time to pass things over to Mary Jean Sage. And Mary Jean, welcome.
Thank you, Tim. Thank you, everyone, for being with us today. We have an important topic that we want to cover and lots of slides that we want to get through in this next hour, so we'll go ahead and proceed fairly quickly as we go through all of them. We will make the slides available to you at the end of the presentation as your screen noted a little bit earlier. So some of them you will use or want to keep for resource as you start getting ready for ICD-10, and we are quickly looking at an implementation date for that coming up. So it is time for all of us to get started with our programs and our plans for getting ready for that. So we basically have four things that we want to cover in the next hour as we go through getting ready for ICD-10. I want to just do a little up-to-date review and overview of ICD-10, the different parts of it, what we'll use each of those for. We want to talk about how ICD-10 is going to affect your practice, some of the technology that you probably already have in your practice, some of the needs you may be needing to look at between now and then. We'll cover a few of the major differences between ICD-9 and ICD-10 so that once again you know where you need to spend your time in getting ready to be ready for that implementation. And then we want to finish up today talking a little bit about some clinical documentation issues. This, I believe, is going to be a major challenge for some of our providers, but it's a very important aspect of ICD-10, and I don't want you to minimize the amount of work we need to do to get ready for that portion alone. So currently we are looking at a implementation date for ICD-10 being October 1 of 2015. For those of us in the industry, we know we've been talking about ICD-10 for a number of years. It keeps pushing back. We don't expect at this time for there to be any further delay. Understand that the implementation date is based upon date of service for your claims. So if you see a patient in the office on the 30th of September, no matter when you submit that claim, you will bill that service using an ICD-9 code. If you see a patient on October 1, 2015, again, doesn't matter when you submit the claim for that, will be using ICD-10 codes for that. The one exclusion on this date of service is inpatient hospitalizations. Inpatient hospitalization services will be based upon the date of discharge rather than the actual date of service. So if you have a patient that is hospitalized starting the 27th of September, they're discharged on the 2nd of October, you would use ICD-10 codes for that entire hospitalization rather than ICD-9. That's the only exclusion or exception to the actual date of service implementation date. So why do we need to change our coding system and go to ICD-10 from ICD-9? As we see our whole reimbursement landscape changing a little bit in the United States and going to more of a reimbursement based upon quality rather than necessarily volume of services, it is the diagnosis that we will use to support that quality. And so therefore, ICD-10 is a much better code set to improve our clinical communications between ourselves and the different reporting bodies that we have. With ICD-10, we are able to certainly report much better data, whether it's a sign or a symptom or some risk factors that the patient might have, as well as some comorbidities. The detail of the ICD-10 codes allow us to do that. And then lastly, we here in the United States are one of the last countries to convert to ICD-10. ICD-10 has been around for quite some time, and a number of countries have already been using that. So we really need to be in a position to exchange information better on an international level. So we do need to go to ICD-10. Understanding, in just a quick review, ICD-10 is put together or developed by the World Health Organization. It is the International Classification of Diseases. There are two parts to ICD-10. Not all countries use both parts. We do certainly here in the United States. ICD-10-CM, CM standing for Clinical Modification, is the diagnosis code set. And it virtually is an updated version of the old ICD-9-CM Volumes 1 and Volume 2, where ICD-10-PCS is a code set for inpatient procedure codes. That's developed here in the United States, and we here are one of the few countries that actually use that. It is the updated version of ICD-9 Volume 3. So for physicians, generally you are not going to be using ICD-10-PCS. Our hospital coders, when they code inpatient procedure services, they will be using that only. Physicians will continue to use CPT codes to report their services to our health payers. There are some huge differences between ICD-9 and ICD-10. One of the things that has caused a fair amount of anxiety for some of our providers is the increased number of codes that are available under ICD-10. On the diagnosis code set side, where ICD-9 had roughly about 14,000 codes, that's increased in ICD-10 to approximately 68,000 codes. On the procedure side, though, take a note here, you'll notice that the procedure code side has increased even more dramatically than the diagnosis code, where ICD-9 had only about 4,000 codes for procedures. ICD-10 has roughly 87,000 codes. So as we worry about having to learn more than 150,000 new codes in ICD-10, be a little assured that the volume is not that great for physicians. Will you need to learn 68,000 new codes? Probably not. You will, in your practice, probably use a few more codes than you have certainly with ICD-9, and that's the important issue is we want you to become familiar with your most frequently used codes and then how to look up any variances that you might have there. But it's probably not going to be necessary for anybody to learn 150,000 new codes. The code structure of ICD-10 is actually very similar to the code structure of ICD-9. We just have a little more detail that we can report with that. So with ICD-10, just like with ICD-9, our first three characters, and we talk in realm of characters now or in terms of characters rather than digits, because ICD-10 is a combination of both alpha and numeric characters. So our characters 1 through 3 are always the category. Characters 4 through 6 then are used to report either etiology, anatomical site, severity, or any other clinical detail that's needed to report that illness. Character 7, and not all codes in ICD-10 have a 7th character, but those that do, that 7th character is known as an extension, and sometimes it's used to report an episode of care, a further complication, or a particular term. So on this slide, let's look at an example of how we can code all the way out to a 7th character using the hierarchy that we just talked about in the previous slide. So S52 is a fracture of a forearm, and that's our category. So all fractures of the forearm would be subcategorized under this. We use our fourth character to tell us the site because there are multiple bones in the forearm. So S52.5 tells us the fracture of the lower end of the radius. Our fifth character here tells us the type of fracture that it is. S52.52 is a torus fracture of the lower end of the radium. Our sixth character, moving on, identifies laterality. S52.52.1 tells us it is that torus fracture of that same lower end of the right radium. Okay? So now we've identified right versus left here. And then finally, this is a code that requires a seventh character, and we use this seventh character to identify our episode of care here. So S52.521A tells us that this torus fracture of the lower end of the right radium, this is an initial encounter for a closed fracture. You would have a different character initial encounter for an open fracture. So sometimes our character that reports extension could be quite detailed itself. Do all codes require 7 characters? No, certainly not. We still, in ICD-10, there are some valid 3-digit character or 3-character codes, just as there were in ICD-9. An example here is hypertension. Our 3-character code is I-10, which is for essential hypertension, and that's a valid code. We don't have to go any further with those codes. And I might just mention here at this point that in ICD-10-CM, the character U is the only character that is not used. In ICD-10-PCS, neither the 1 or neither I or 0 or O are used because they didn't want them to be confused with the 1 and the 0. But in the diagnosis code set, U is the only character that isn't used. So going forward, building a 5-character code, we again have E11 here as our category, which is type 2 diabetes. There would be a different category for type 1 diabetes. That's a change from 9 to 10. Our 4th character here identifies the complications that are associated with this diagnosis. E11.4 is type 2 diabetes with neurological complications. Because diabetes codes in ICD-10 are what we call combination codes, we have to go 1 character further to identify the type of neurological complication for this patient. So E11.42 tells us it's type 2 diabetes with polyneuropathy. Building a 7-character code follows that same format. We just keep going with additional characters. So in our example here, we've used chronic gout. So M1A is chronic gout versus a different category that you would have for acute gout. M1A.0 tells us the type of chronic gout. In this case, it's idiopathic chronic gout. Our 5th character, again, tells us the site, the anatomical site, idiopathic chronic gout of the ankle and foot. We use our 6th character to identify laterality, that it is the left ankle and foot, and then we use our 7th character to identify a complication here. So it's idiopathic chronic gout, left ankle and foot with tophus. So as you can see, it does get more detailed as we go forward with this, and it's important that our documentation support everything that we have coded out for this. So what does changing from ICD-9 to ICD-10 mean for your particular practice? The code sets alone, remember, that will be requiring some significant changes to both our clinical and administrative systems that capture and report diagnosis codes. So we certainly use more systems in our practice than necessarily our billing system or electronic health record. You might be using a system for appointment scheduling that uses diagnosis code. You might be using a different system for quality reporting that would use a diagnosis code as well. So it's important that we understand we have multiple systems in our practice that do use diagnosis codes, and we have to get all of those systems ready to convert to ICD-10. The structural differences between ICD-9 and ICD-10 alone make converting the code set more complex. And the change in character length alone from a possible 5 up to 7 requires that some system upgrades to expand that data field for the longer codes must take place. And I think that most of you will find that your software companies or systems have probably already made the upgrades necessary to go from ICD-9 to ICD-10, whether you've purchased those upgrades and installed them, or perhaps you've purchased them, they've been installed, but you haven't been instructed as to how to use them yet. So that's what we should be spending our time now getting ready to do that. So to begin this whole process, you need to take a look throughout your entire practice and determine where you use diagnosis code, starting right at the front desk when that patient first calls for an appointment, when they come then to first be seen, and if they go back to the front desk to check out. So a good way to determine where you use ICD-9 codes is just to follow a patient from the time they call to make an appointment until they're seen and they're ready to be discharged from that particular encounter. So from a front desk perspective, some of the things that you have to look at is you will want to take a look at your HIPAA privacy policies. If you have used diagnosis codes to explain some illnesses or talk about different symptoms in those, you may need to change those forms. And remember, every time you change those privacy policies, you need to ask the patient to sign a new form. So that might be a change that you'll need to be that you will encounter. The systems themselves that you use up at the front desk, sometimes they're not the same systems that we use back in the clinical area. So you'll want to take a look at the systems that you use and how they interact with diagnosis codes. Back in the clinical area, you want to consider patient coverage. Remember, patients don't necessarily all have the same type of health insurance coverage, and sometimes that coverage is based upon medical necessity, which of course relates to a diagnosis of some kind. So some health plan policies will be changing. We'll need to take a look and see how those are changing. You may find that payment limitations differ from what they did under ICD-9, and we'll want to know what those changes are. And then finally, back in that clinical area, this is where we sometimes have the patient sign an advance beneficiary notice if we think something may not be covered from a medical necessity issue, so those forms may have to be changed as well. A number of us still use superbills, whether it's a paper superbill or an electronic superbill. So that's going to have to change as well. It probably is unlikely that a paper superbill can still be used if you have lots of different codes, because they would become unwieldy and may have to be more than in one page. But we remember that we often use an electronic superbill as well. So not only would you have to change your paper superbill, but you'd have to look at formatting an electronic superbill differently. And then again, remember your advanced beneficiary notice, because most health plans will revise those policies, and they're all linked to coverage determination policies, whether they're local or national. And if you formatted any of your ABN forms with either CPT codes or ICD codes, the ICD codes will need to be changed on those. From a nurse and medical assistant perspective, they use lots of forms. We have all kinds of authorization forms. We have all kinds of referral forms that we will need to take a look at and see if there are revisions or if they need to be reformatted or recreated. Documentation is a very important issue with ICD-10, so both nurses as well as physician providers need to understand that there is a great deal of increased specificity from a documentation standpoint. We will need to make some changes there as well. Also remember that very often our nurses and medical assistants fill out those forms for requesting for prior authorization. Before we can ask for prior authorization, we always have to give a diagnosis code, so those need to be changed as well. From our physicians and extender standpoint, documentation is probably the biggest issue for them. Because of the increased specificity of the diagnosis, we're going to be looking at much more detailed documentation to support the diagnosis code that we use. So again, we do need to train our physicians and our extenders probably spending more time on documentation rather than perhaps code selection, although in order for them to understand what they have to document, they have to understand the coding structure itself and why we now have all of these, for instance, combination codes for diabetes, and therefore we are asking them to be more specific about the complications that the patient has. From a laboratory standpoint, again, diagnosis codes are used to support medical necessity for ordering laboratory studies, so documentation becomes an issue there as well. And then from a reporting standpoint in the lab also, because health plans will have some new requirements for both ordering and reporting of services, again, our codes become very important there. From our coder standpoint, whether your coder is also your biller or whether you have a coding staff on hand, the code sets become very important because of the way that they have changed. Our ICD-10 books look a little bit differently. Our format and some electronic systems will look a little differently also. There is a need for some increased clinical knowledge in coding with ICD-10. Does this mean that you need to send all of your staff members out to a full-bore anatomy and physiology class? Perhaps not, no, but I think that we do need to have a little bit of a brush-up, at least on general medical terminology and perhaps some anatomy as well, because it does become a little more important with ICD-10 and making code selection. Also, from a coding and billing standpoint, understand that for a while we will have to be able to still use ICD-9 and ICD-10, using them concurrently, because you're all going to have a period of time where you still have some claims that haven't been resolved, either from a standpoint of claims have been held up for payment, or maybe they've come back requesting some further information, or you may have some claims on appeal. So again, your implementation date becomes important here. You will have to be using ICD-9 for things prior to October 1, 2015, 10 for everything October 1 going forward. But there will be a period of time when you'll need to be able to use in your systems both ICD-9 and ICD-10. From a purely billing standpoint, policies and procedures from our health plans are probably going to change. Policies and procedures may actually change in your office, and they may be changing on a temporary basis or a permanent basis. You may find at the time of implementation it's taking longer to get your services coded, therefore longer for the claims to go out the door. So we may need to make some temporary workflow changes to accommodate that. Also, I think that probably, without a doubt, it is our billing department staff that needs to be trained the most comprehensively on ICD-10, because they're going to need to know the whole system, start to finish, including all of the policies and procedures, as well as all the possible code set that they could be using. From a managerial standpoint, this is our person that's going to oversee everything and have a running knowledge of everything that's going on and keep track of the timeline and make sure that we're set to go here. So our managers want to take into account if you're going to have to institute some new policies and procedures, what's the timing of that going to be, and what kind of revisions are we looking at, not only from a system standpoint, but again from a workflow process standpoint. Probably it will be our manager or her designate at least that takes a look at all your vendor and payer contracts, because these are going to have to be reviewed and evaluated. You're going to be getting some new contracts probably from some vendors. Payers may not be sending out new contracts right away, but as they change their policies and procedures, they're going to be updating their contracts as well. It's also the manager that should be looking at the budget and make sure that you have accommodated from a financial standpoint everything that you need to, whether it's a change in software, how much are you going to be spending for training, what kind of new paperwork are you going to have that needs to be recreated. And then also this, I think an important thing for our manager is to take a look at the training plan, make sure that everybody in the practice, because everybody in the practice needs training, everybody in the practice is getting training. That doesn't necessarily mean that we train at the same level. There is an article in one of the upcoming issues of capsules that addresses training needs and how you determine who needs to be trained on what. So I think, are all agreed at this time it's time for us to get going with this. October 1 is only a few months away. Some of you probably have a fair amount of work to be done. So basically it comes down to 4 things that you need to do. You need to prepare a project plan that encompasses everything that needs to be done. You need to take a look at your practice, perform what we call an impact analysis. Again, this is where I use diagnosis codes. This is how I use it. Do I need to relook at who's now providing this diagnosis code? Then you need to start implementing. We can start implementing by educating about ICD-10, doing some testing when our clearinghouse and our payers allow us to do testing. Then come October 1, we need to convert to ICD-10, and then don't forget that you need to monitor the whole process. I think probably as we convert on the 1st of October, we may not see a lot of change the first quarter or so, but the 1st of next year, maybe even the first 6 months of 2016, I think that's when you're going to see the health plans coming back and say, I need to have more information about this to support the diagnosis that you're billing out here. Please send your medical records. And in the meantime, I'm not going to pay your claim. I'm going to hold it up until I get those records. So now's the time to get our group together and get started working on this. So basically you have 8 tasks, if you will, that you need to do between now and October 1. Some of them you need to get started on now. And that starts with, as we talked about, identifying your current systems and where they use ICD-9 codes. You need to start talking with your practice management vendor and practice. Basically, we use a number of systems in our office. So practice management is our billing system. If you have a separate vendor or a different vendor for your electronic health record, you want to be talking to them as well. What are they, doing about getting ready for ICD-10? What's the timeline for starting to use it? How much is it going to cost you to upgrade if you're going to have to upgrade? You want to make sure that we discuss the implementation plans with all your clearinghouses that you use. If you outsource your billing and use a billing service, you want to make sure that you're communicating with them, as well as some of the payers. Most of your payers on their websites, they all have a portal for ICD-10 at this time, and that's where they tell you when you can test, what nuances, if any, their payment system has with ICD-10 and how you can get ready for them. So it's important for you to now to start assessing what each of these are doing and where you are with that. If the billing service, for instance, says to you, don't worry, we have it covered, we'll take care of you, you want to be a little leery of that. Obviously, the billing service is just going to send in whatever it is that you send them, but you need to, in your practice, be in a position to do a good job of coding before you ever send it to either a billing service or a clearinghouse as well. I want to make sure that you understand the importance of talking with the payers about the ICD-10 implementation and how it might affect any of the contracts that you have with them. Hopefully you can all find your contracts that you have with them and take a look at from a practice a requirement standpoint or a practice policy standpoint, clinical practices, I'm talking about what would be important and how they're looking at diagnosis codes. You want to make sure that you identify any potential change to workflow and business processes. What you want to take into account here is it's going to take some extra time for us to address clinical documentation and the need to be more specific for that. Do we have to order any new forms of any kind or reformat forms if you have electronic forms? What about quality reporting? What system do we use for that? And do we need to make some changes as well? Public health reporting. What do we have to do with public health reporting? And if we're reporting to public health, does the public health system, are they going to be in a position to be able to accept ICD-10 codes? Don't forget the importance of assessing the staff training needs. Not everybody needs to be trained. Not everybody needs to be trained at the same level. So it's important that you take a look at your entire staff and determine, how you're going to do, what training needs to be done first, and then how you're going to do that training. Can the entire staff participate in some training together, like an overview of ICD-10? Basically, everybody needs to have that. So perhaps the whole practice could attend or participate in that. And then you get into more specifics about the coders need a little bit more detailed than perhaps the medical assistants or your front office people. But you really need to take a look at the entire staff and see who needs what. Don't forget that there will be a period of time, and you will want to test some of your transactions to make sure that the systems are all in place and everything is ready to go for ICD-10. Remember, testing is just that. It's testing, and it's not actually submission of claims. So if you go through and do testing, just like remember when we tested when we went from the 4010 format to the 5010 format and getting ready for ICD-10, when you test, you have to resend that batch of claims for it to be live and go actually through to the adjudication system itself. So there is a lot of talk about dual coding, and that's coding in both ICD-9 and ICD-10. And yes, and it can be kind of expensive if you're doing it manually, but if you can use your software to do dual coding, for instance, in some practices now the software has the ability to, you put the ICD-9 code in, it can automatically convert it to an ICD-10 code, then it has to get converted back to the ICD-9 code again before the actual claim goes out. So dual coding is an option. You probably want to do it for a while, but to make it a real positive option, what you want to do is take a look and see why whatever I sent ICD-9-wise couldn't be converted to an ICD-10 code. That'll tell you where we probably have to do some more training with some of our staff. Make sure you watch for testing periods. Payers don't let you test whenever you want to. You usually have to sign up for the testing. Most of us will actually probably engage our clearinghouse and test through our clearinghouse. So there is a little communication and some planning that needs to go on that. With that, we know CMS or Medicare is testing now. They had a testing period in 2014. They had a testing period just a couple months ago. They have another testing period that's coming up in July. Not everybody will qualify to test, and you do have to sign up or register to test if you want to. Lastly, our eighth task is don't forget the importance of the budget. While the cost for a practice to convert to ICD-10 have probably been overestimated by some organizations, and we do have some studies now that show us that converting for a smaller practice will be less expensive than we initially thought, it is still important for us to plan for the cost and budget both time and cost. Don't forget the importance of time equating to cost also. And when you're doing your budget, make sure that you budget out-wise. Don't just stop with what you think you have to do before October 1 of 2015. Budget for all the way through to the first part of next year, because again, you may want to have a little bit of a reserve fund on hand, and you also may find that after implementation, we have actually more problems with our claims being held up than we did with the initial implementation. So a couple words about technology and how we can use it effectively, because technology will have a lot to do, and it has a very important part in converting to ICD-10, although that's not the only issue. So you do want to, as we've been talking about, start to work with your vendors now. You want to know what they're doing for ICD-10, when they're doing it. Can you have access to both ICD-9 and ICD-10 codes in both your practice management and your EMR system, and for how long? Just stop and think about how long we sometimes have some claims out there for appeal. Some of them are really tough ones, can be out on appeal for close to a year sometimes. So you don't want your vendor to say to you, yes, you can have the first quarter after implementation, you can have access to both ICD-9 and ICD-10, but we'll only be supporting ICD-10 after January 1 of 2016. That's probably not long enough for you. You want to make sure that you have access to both code sets just as long as you need it. You want to identify all those internal systems that use 10 again, understand the changes that you have to make to each one of them, and also understand that from a technology standpoint, sometimes when we make a change in one data system, it may have an effect automatically on another system. So, for instance, if we change in our EMR, what effect is that going to have on our practice management side? Will everything go automatically over there, or do we have to make some additional changes of some kind? And then the impacts on staff, process, and all the other systems that you have in the office as well as a result of some technology changes that you've made. You may need to, in this whole course of transition, identify if there's maybe some new technologies out there that you haven't been using, but you do want to use them. Code mapping is a system where we can convert from ICD-9 to ICD-10 code mapping. If you're looking at code mapping, you want to make sure that it is a two-way crosswalk, that you go from 9 to 10, and then you go from 10 back to 9 as well. So if you're looking at one of those systems, just make sure that it's not just a one-way only. I get questions frequently from physicians that say, well, somebody told me that when we move to ICD-10, I'm going to absolutely have to have an electronic health record. I won't be able to do ICD-10 without an electronic record. That's not true. You can. Certainly, it might be a little more difficult for you to do it, non-electronically, but you could do it. There's nothing in the conversion to ICD-10 that mandates everybody goes to an electronic health record, although it certainly would be helpful. We heard a lot in our earlier transition history about the GEMS, the general equivalency mappings. That's the data system or the mapping system that was developed by the CDC along with CMS, which is because there's not it's like a crosswalking system. There's not an actual one-to-one crosswalk from 9 to 10. Do we have to learn about general equivalency mappings? You need to be aware of them and what they are and how your vendors are using the GEMS. I don't know that you necessarily all have to learn that entire system. It's actually quite confusing, and it is meant to be helpful as far as that goes, but it's actually quite detailed. Most of your translation software packages will have used GEMS in some way when they developed that software. So as you're talking with your vendors about crosswalking and what kind of options they're going to give you, you just want to make sure that when they've developed their software, they've used GEMS in some way. So just to clarify a little bit, this translation programs and the software that's behind them, some of these software packages come with your billing software or your EMR, your electronic healthware software. You can purchase some additional software that will do this translation for you. Some of these packages are actually free. You can go online and you can crosswalk. I've given you a couple of examples here, but there are other examples out there as well. Just a word of warning, though, about translation programs. While they are good tools, and I think that we should use them, what we're going to see as a tendency, I'm sure, is that we use the translation programs instead of our books. And I think that will come back to haunt you at some point. What I would rather see you do is not use this translation software instead of the book, but use it in conjunction with the book. So crosswalk to the ICD-10, and then when you have that code, just check it out in the ICD-10 book to make sure that that truly is the diagnosis that you intended on reporting there. So use the two of them as tools together rather than one versus the other. So remember, from a major standpoint, our two systems that are most affected in the office are going to be our medical record system and our billing system. The next few slides that I've given you here are just some questions that you want to be asking your vendors. Some of you have probably already been working with your vendors and maybe have gone through a part of this, but now's a good time to just go back through these slides and take a look and make sure that you've covered everything that you want to. So timeline is always important. When are they going to transition to ICD-10? Maybe you can transition now, but when will it actually go live? And again, remember that that's going to be a challenge for all of us because there's no grace period, if you will, for ICD-10. It's a drop-dead, do one system on September 30th, go to a brand new system on October 1. So you want to make sure that you fully understand with your software vendor when they're going to actually make the transition. You want to know from them, do they offer any kind of ICD-9 and ICD-10 comparison utility where you first crosswalk them and then they tell you the differences between the two codes so that you confirm that you did actually do the correct selection. When can you do testing with their software and your different trading partners? When will they be upgrading your system, and are they upgrading on a different timeline? For instance, upgrading on the electronic health record at one point, upgrading in the practice management side at a different time frame, because if you're going to use both of them together, you want to make sure, obviously, that they are in sync. One of the other things is you'll want to know how you can search the codes in their system. Do you have to search it by numbers, numerically? Can you search it by description? And if you can do it by description, how much of the description do you have to have in there? Can you search both the alphabetical index as well as the tabular index? Because we have both of those indexed in ICD-10 just as we did in 9. And can you even search by clinical concept as far as that goes? Also, as I mentioned before, important issue is how long will ICD-9 be available to them. And make sure, I think, that one of the things that we always want to ask our vendors is, do they provide anything specialty specific for whatever your specialty happens to be? Do they, for instance, provide some templates for the most frequently used diagnosis codes in your specialty? I think you have to use that as a starting point. Again, take a look then at those templates and see if those truly do report the diagnosis that you intended for them to do. So with that, let's go through some of the major differences between now and between ICD-9 and ICD-10, so that we have a basic knowledge of where some of the changes are and what you need to do. So from an organizational structure standpoint, the two systems are very similar, as I talked about before. The first three characters are always the category. All codes within the same category have some similar traits. However, in ICD-10, there are many more categories, so they have subdivided from ICD-9. So, for instance, diabetes is a good example. E10 is type 1 diabetes. We have a different category for type 2 diabetes now. E11 is type 2 diabetes. J45 is asthma. And then we have subcategories or subclassifications under asthma to report the different, it's still asthma, but the different types, whether it's mild intermittent or mild persistent, and then they go on to more severe coding from that point on. There are some differences that are actually physically seen in the organization of the book itself, or the code set, I should say. ICD-9 had 17 chapters. ICD-10 has 21 chapters. The old V and E code supplemental classification in ICD-9 are now actual chapters in ICD-10, so those are 2 of the 4 new chapters. The other 2 new chapters are the diseases and conditions of the sense organs. The eyes and the ears have been separated out from the nervous system, and each has their own chapter now. So that's how you get the 4 additional chapters. Here's a list of the chapters as they are, and we've identified what the new chapters are. You'll see that some of them, for instance, I don't know that it was necessarily planned this way, but it is how it's worked out. Diseases of the musculoskeletal system, they all start with an M. Diseases of childbirth starts with an O, as in obstetrics. Endocrine system, they start with an E. Some chapters go across a couple of the alphabet letters. Some letters of the alphabet actually cover more than one chapter itself. So there's some similarities there. There's not, it's not a start to finish always that way. And again, the letter U is not used. It's being saved for some updated and further development of ICD-10. that certain diseases in ICD-10 have been reclassified from what they were in ICD-9, and they've moved to different chapters. Gout is a good example of that. It used to be in the chapter on the endocrine system. It's now in the musculoskeletal chapter. Where ICD-9 always classified injuries by type and then anatomical structure under that, ICD-10 does it the other way around. It groups them by specific site as head, leg, arm, whatever, and then the type of injury, fracture, contusion, open wound after that. So that's just reversed. Another change is that postoperative complications have been moved up to the procedure-specific body system itself. So where postoperative complications used to be a lot of them in the V code category in ICD-9, they are now actually up into the system chapter. And for the most part, they're always at the end of that chapter, or at least at the end of the subcategory of those chapters as well. A couple of other changes, obviously, ICD-10 is now alphanumeric and can go all the way up to 7 characters, where ICD-9 was just numeric. ICD-10 does include what we call full code titles for all codes, so you'll be seeing much less of the use the following fifth digit for this subclassification. So remember in ICD-10, for instance, I've given you an example here. With this code category, you could use 1 for unspecified, 2 for status asthmaticus, 2 for acute exacerbation. You will no longer see any of those. The only exception to that is there are a few codes that require a 7th character, and there will be an indication up at usually a subcategory level that will tell you that these are the options for 7th character. There is obviously an addition of a 5th character in some chapters, also an addition of a 7th character in some chapters, primarily obstetrics, injuries, and external causes. In ICD-10, we have what we call a placeholder, and I want to just briefly explain what a placeholder is. So a placeholder is always an X, and it is put in place when you have something that has to go out to generally a 7th character, but you don't have an appropriate character to go in either the 5th or 6th category. Then you fill in that hole in the code, if you will, with the X. And I have given you a couple of samples here. So the placeholder would never, ever be a 7th character, but it could be a 5th or a 6th character. Here's another example. All of our codes in our external causes are 7-character codes. This is an example where we need to put the placeholder in the 6th character. The 7th characters, again, are primarily used to report an episode of care. If you need, once again, a 7th character and don't have a 5th or a 6th, you're going to use a placeholder in that spot. Another thing that's quite different in ICD-10, there are lots of what we call combination codes. Diabetes is a good example of this. Arteriosclerotic heart disease is as well. These are codes that are, from a documentation standpoint, going to expect to see a lot more documentation from our physicians. So from a diabetic standpoint, we see that I need to know what the complication is before I can code it, and then I need to make sure that my documentation in the medical record supports the code that I did use. Combination of codes are also prevalent in the poisonings and external cause chapter. Laterality is an issue in ICD-10. That's what's, right versus left. Sometimes you'll report it using bilateral versus unilateral. There is, generally speaking, always an option for unspecified when you're reporting laterality. Now, can you continue to see the patient time after time after time and bill with an unspecified site for a fracture? Probably not. You could probably bill it once and probably get paid from the health insurance company. But if you, bill very often, they're going to come back to you and want to know why it is that you don't know what side of the body that fracture is on. So get used to reporting laterality in your medical record documentation. There are some expanded codes. Again, we often call these the combination codes that I talked about before. The endocrine system with diabetes is an area that have a lot of expanded codes. Drug and alcohol abuse codes are also a category of codes that have a lot of expanded codes in there. From an obstetric standpoint, the inclusion of trimesters is mandatory. They've eliminated that fifth digit or character, if you will, for episode of care, but we do have to always report what the trimester is, and there's a coding guideline that tells you how to determine the trimester. There are some changes in time frames in ICD-10. If you're reporting myocardial infarction diagnosis, they have minimized the time frame for the acute status from 8 weeks to 4 weeks. From the obstetric standpoint, they have changed the time to determine whether it's an abortion versus a fetal death has changed from 22 weeks down to 20 weeks. Again, there are general coding guidelines to address both of those things, and so you'll want to take a look at that and put some time into studying those to make sure that you have them correctly. Another thing that I do definitely want to mention to you is there are two kinds of excludes in ICD-10. There's an excludes 1 and excludes 2, and I have given you the definitions here or the differences between them. And excludes 1 always reads or notes that you're not to code these two things together. So basically it's telling you the patient could never have these two conditions together. And excludes 2 tells you that this code or this illness is not necessarily included in this, but you could possibly still build the two or code the two of those together. Most of those are things that could be either acute or chronic, and it would be possible for the patient to come in for an acute episode but have chronic, and pharyngitis is a good example of that. So how do you start here? What you need to do now to get ready to start switching over to them is determine what your most commonly or most frequently used codes are and try to convert those ICD-9 codes to ICD-10. On the slide here, it's basically a 4-step process. You want to generate that report off of your practice management system, sort it by frequency so that you can pick the top 25 or 50, depending upon how much time you want to put into this, then convert those codes to ICD-10 codes. And then go back and look from an ICD-9 standpoint as to what's the difference there, and from a documentation standpoint, what are the variables that you're now going to have to see documented. And then you want to go back and audit that between now and the time we convert to ICD-10 to make sure that you're getting the documentation you need to support those. Some challenges from a documentation standpoint as we finish up here. Always remember the golden rule. If it's not documented, we didn't do it, therefore we can't bill for it or we can't code for it. Because we have multiple combination codes, we're going to have to increase the specificity of the documentation that we see. Crohn's disease is an example of where we have much more detail that is needed. Laterality, always an issue. Make sure that we get that documented. Is it right or is it left? The combination codes, an example is in diabetes alone. In ICD-9, we only had 59 codes. We have more than 200 in ICD-10, and it is all because we are now reporting the same category, but with the complications. If you're billing for or coding for a diabetic patient, if they have multiple complications, you will be using multiple codes to report this. Injuries, again, injuries are one of those things that require a episode code of care or an extension code. So understand what your possibilities are for the different types of injury and make sure that your documentation supports that episode of care as well. The causes of injury should be documented and coded as well. Should be is the key word here. Documentation is the important thing. Will you bill for external cause codes? What we're telling you now is if you build E-codes before, telling us how that injury happened, then you should continue to bill external cause codes. If the payer hasn't requested the E-codes up to this point, then you probably don't need to initially start out doing that. You will probably see more payers in the next year or so ask for external cause codes to be reported, so understand how to use them. A new term in ICD-10 is drug underdosing. So there are multiple codes for that identify the situation in which a patient hasn't taken the prescribed amount of medication. And then there are subcodes to tell you why they haven't taken it. So you would always code the medical condition first, then the drug underdosing code, and then as a third diagnosis, you would put the reason why they didn't take it. Either they forgot to fill the prescription, they didn't have money to get the prescription, they got the wrong prescription from the pharmacy, actually. So this would be 3 different codes that you would have to report for that. And since this is a new concept, we will need to work with our physicians to make sure that we get this documented correctly. There are some documentation challenges associated with cerebral infarctions, acute MIs, again, because of the time frames, musculoskeletal conditions, laterality is an issue. I've given you a little warning here on the bottom of this slide about using unspecified too often. Yes, unspecified is still part of ICD-10. You can code it probably just as much as you want to, but think about what that's going to do to your data that's now being reported in a few years from now. When you come back and they look at quality, you're not going to have the specificity that you need there. So right now, get used to reporting not only the laterality, but the type of fractures, and I would love to see you take that whole word unspecified out of your vocabulary, and that probably is not going to happen, but minimize how you're using that. Again, documentation-wise, there are some new things with reporting pregnancy, and so you want to make sure that you understand how to determine what the trimester is, also the detailed that's going to be required for some of those things. From a respiratory system or vent standpoint, there are some timelines that are now part of that, the coding system, determining whether the patient is on a vent less than 24 consecutive hours, 24 to 96, and then greater than 96. That will determine one of the characters that you put on the code itself. And just a final couple of reminders to make sure that we transition carefully. Your clearinghouses are going to be able to help. They cannot be quite as helpful as they did when we switched from 4010 to 5010 because we have lots of issues that are not IT related with converting to 10 at this point. They can only do with the information that you give them. So the physician still needs to do the coding. You need to send the correct stuff to them. CMS has told us that they are recommending regular documentation audits after implementation to make sure that your clinical documentation supports your ICD-10 code. That should just tell us that we're going to be seeing more audits from everybody. CMS will probably start with the Medicare program. Then you'll see your private payers start from there, go pick it up and take it from there as well. So, again, documentation becomes extremely important. And, Tim, with that, I think we're down to, if we have a couple minutes for questions, we can take some of those. Mm-hmm. If not, I think we are going to answer all of your questions and then make those answers available to everybody.
That's absolutely correct. That the Cooperative of American Physicians will compile all of the unanswered questions today, and we'll work with Mary Jean to answer some of the remaining questions. And additional information will be emailed to everybody attending today. So please check your inbox, and you'll receive that, along with an email of the presentation slides and the webinar recording. So check your email. It should take a couple of weeks for us to get that to you. But sadly, the clock is relentless. We have a lot of territory we covered. Mary Jean, I want to thank you for a very informative presentation.
You're welcome. Thank you all for being with us.
And that concludes today's Cooperative of American Physicians webinar, Building a Path to ICD-10, brought to you by the Cooperative of American Physicians and CAP's Practice Management Services Committee. This is part of the Surviving and Thriving Through Healthcare Reform webinar series. And again, special thanks to Mary Jean Sage for a terrific presentation today. As I mentioned, CAP will email the presentation slides and a webinar recording to all attendees within a couple of weeks. We are also compiling the questions from today's webinar, and we have quite a few, and we'll work with Mary Jean to answer some of the good questions and email you additional information on that. When I end the webinar, your computer will go to an online evaluation form for today's program. We very much appreciate your comments and suggestions so that we can bring you future quality programming. Today's program is copyrighted in 2015 by the Cooperative of American Physicians, all rights reserved. Thank you for joining us today, and enjoy the rest of your day.
The information in this program should not be considered legal advice, applicable to a specific situation. Legal guidance for individual matters should be obtained from a retained attorney.